So, but my pleasure this morning to introduce Katie Benziger. She was a summer intern here in 2005 and was assigned to work with me her first summer, and then stayed on as a research assistant for the following year. But the reason I'm showing her poster like this is as we were looking for photos of her at her poster, we realized in 2006 we used our phones for making phone calls, and we didn't. There may be a picture of her at her poster, but we don't know where that is. So Katie did this project. I gave it to her as an idea. She did a phenomenal job, presented it at ACC, struck up a conversation with Marie Serrano at the meeting, who was very interested in the topic. And then we had a couple other papers, and she worked with other people as well. So she was a highly recruited soccer player at a D1 level, ended up switching to McAllister, where she played soccer, presented this as a senior thesis, and went on then to med school at the University of Minnesota, did a Fogarty program in Peru, and then did her training in internal medicine and cardiology in Seattle before returning to Minnesota, where Duluth was fortunate enough to recruit her. But what's really cool is, as a graduate of our summer intern program, she has now started her own summer intern program at Essentia. So she's an adjunct associate professor at the University of Minnesota Med School in Duluth, specializes in heart-related conditions such as cardiometabolic disease, which we'll hear about today. She's been the medical director of the Heart and Vascular Research at Essentia and leads a large research team. She is the site PI for Essentia and the STAR Clinical Research Network, which is one of the top enrolling sites in a number of pragmatic trials. Her work is dedicated to enhancing heart health in rural areas by preventing diseases like diabetes, high cholesterol, and heart disease through research and education. She's done a variety of national organization leadership committees, such as American Heart Association, Cardio Health Alliance, and Minnesota chapter of ACC and National ACC production. So my pleasure to introduce Katie.
Thank you so much, Dr. Harris. It is really, thank you for that generous introduction. It's really full circle to kind of be back up here. My first time speaking was preparing for that Atlanta ACC meeting in 2006. We did a little run through with some of this other summer interns. It wasn't in this room, it was down the hall, but it's really a great program that you have that really taught me what it was like to be a cardiologist and a researcher. And it's something that I've never forgotten and has really continued to lead me to where I am today. It really started right here in this building, and the building really hasn't changed that much. The elevators are the same in the lobby. And I was walking by and I was like, oh, that was Dr. Marin's office. And I remember where everyone sat, So anyway, thanks again. Today I'm going to talk about what is the cardio-kidney-metabolic syndrome. And these are my disclosures. I'm a site PI for a number of lipid-related trials and national lead for the Victorian-1 PREVENT study on inclisiran. So we're going to talk about the cardio-kidney-metabolic stages. We're going to talk about what we should be doing to screen and manage these patients, and then considerations for when you might need to refer to someone who's specialist in this area. And a lot of this is coming from the Cardio-Kidney-Metabolic Health Presidential Advisory from the American Heart Association, and there'll be updated cardio-kidney-metabolic guidelines coming out in the new year. So before we talk about what is the cardio-kidney-metabolic syndrome, I want to just ground us with a case that I think is probably very familiar to all the cardiologists in this room. You probably see this in your clinic today, if not sometime later this week. This is a 65-year-old female, comes in with a recent ST elevation myocardial infarction. She's obese. She had a PCI to her right coronary artery about a month ago in the hospital. She had a new diagnosis of type 2 diabetes. She has high cholesterol. She's got moderate peripheral arterial disease, and she's smokes about a half pack a day. I will say this is our typical Northern Minnesota patient. She's currently feeling well and was asking, what can I do? I don't want to have another heart attack. That was a really terrible experience. What can we do to improve my health and reduce my risk? She has quit smoking, which I congratulated her for. This is at the time of the visit. Her vitals, blood pressure was a little elevated, 139/89. Her weight's 264 for a BMI of 35. These are some labs that were from the hospital. They hadn't been repeated. Her creatinine was 1.4. Her A1C was 8.4, LDL 168. Triglycerides were in the 300s. And echocardiogram showed some moderate concentric hypertrophy, normal ejection fraction, no wall motion abnormalities, and some grade 2 diastolic dysfunction with elevated filling pressures. This, I'll be honest, is a case from a couple years ago. She was put on dual antiplatelet therapy, aspirin and Plavix, atorvastatin, metformin, and glipizide. And again, had a history of heart disease, and her dad in his 60s had been smoking since the age of 16, but quit recently. And so when we are talking about cardio-kidney-metabolic disease today, I just want you to think about this patient or someone that you're seeing that has a similar history, maybe is on similar medications. And we need to think a little bit more holistically, not just about this as being a STEMI patient, but this being a stage 4 CKM patient. And if you're not familiar with that terminology, we're going to go through that today. So this is a stage 4 CKM patient that needs optimization of many risk factors and medication changes, which I'll review at the end. So we all are very familiar with heart attacks. They are cause of a lot of sleepless nights for our interventional cardiologists and phone calls for the non-invasives and calling from ERs of patients with chest pain. They affect over 800,000 people a year. That's 1 every 40 seconds. And over 9 million people have cardiovascular disease. But heart attacks aren't just a binary thing. Cardiovascular disease is a spectrum. And so while on the far right-hand side, we have these major events, prior myocardial infarction, stroke, people with symptomatic peripheral arterial disease. Those are your highest risk patients, those who have known or established atherosclerotic cardiovascular disease. This is a spectrum, and we're increasingly recognizing the need for imaging and prevention that is starting earlier on in this spectrum. So from the left, we have those who are low cardiovascular risk. Those we would often probably describe as CKM stage 0, maybe CKM stage 1, which we'll again talk about. And then once we start developing risk factors such as diabetes and then having established coronary artery disease, maybe seen on imaging, having a prior stroke or TIA, things and other disease, then we are developing atherosclerosis, but maybe we haven't had a major event. And there's been some big lipid trials looking at being more aggressive with the PCSK9 inhibitors. Fourier and Odyssey outcomes were published over 5 years ago. You're probably very familiar with these in reducing events in the highest risk group. And if anyone was at AHA a couple weeks ago, Vesalius was published, and we were a site for Vesalius. And that's looking at, again, PCSK9 inhibitor, evolocumab, for these next sort of higher risk group patients. And I'll talk about that in a minute. So I think we need to start thinking again, rather than waiting to send in the firefighters when someone's having a heart attack and trying to put out the house fire, we really need to focus on prevention and putting in more smoke detectors and early warning signs when people move from stage 0 CKM to stage 1 and from stage 1 to stage 2 CKM and getting them back to healthy and a healthy weight and not developing the downstream effects which are much harder to treat, as we're familiar with. We obviously need our interventional cardiology colleagues and our firefighters in cases of an emergency, but we really want to be focusing our efforts on prevention. So what is cardio-kidney-metabolic syndrome? It is a health disorder attributed to the connections between obesity, diabetes, chronic kidney disease that leads to multi-system organ dysfunction, particularly cardiovascular disease, atrial fibrillation, heart failure, and end-stage renal disease and stroke. It's really important that we define it. And again, there's going to be 5 stages, stage 0, 1, 2, 3, and 4. We need to screen for this on a regular basis based on people's risk factors. It's recommended that we use the new American Heart Association Prevent Risk Calculator to help with risk stratification of these patients. we should be routinely assessing social determinants of health, which I think both in your health system and ours is integrated into the EHR and my chart process for many patients. And then once we identify where people are at, we need to do a more aggressive job at preventing progression to stage 4 CKM and managing their risk factors. So I'm going to take a minute just to go over this figure of the stages of CKM. I hope everybody in this room is on the left-hand side here in stage 0 CKM. Really, that's folks who are healthy, have no risk factors, are focusing on life's essential 8. Those are the 4 health behaviors and 4 health factors that the American Heart Association says we all need to have a heart healthy life, sort of free of all the downstream cardiovascular disease you see here. As soon as you develop a BMI over 25, outside of the normal range, you move into stage 1 CKM. And this is particularly important for people who have abdominal obesity. So some ethnicities, you can have a normal BMI and still have a lot of abdominal obesity, and that can be dysfunctional adipose tissue that leads to some of the impaired glucose tolerance and setting the stage for some of these stage 2 metabolic risk factors. In the past, we've talked about metabolic syndrome. This is a little bit broader, holistic look at metabolic syndrome. A lot of our metabolic syndrome risk factors are in stage 2 CKM. That's hypertension, hypertriglyceridemia, type 2 diabetes, high cholesterol, moderate to high risk chronic kidney disease. And there's a lot of interplay between these risk factors, as you can see with the curved lines in the middle. But there's also sometimes etiologies that are not related to metabolic syndrome that can contribute to development, for example, of hypertension. A lot of our patients, even if we're seeing them for atrial fibrillation or for other conditions, have stage 2 CKM. And I think recognizing that those risk factors are in that stage 2 category and that they're at high risk for progression to stage 3 and 4 is really important. Stage 3 CKM is when you start to develop subclinical cardiovascular disease and underlying, like on imaging, right, on a cardiac CT or coronary artery calcium scan, starting to see evidence of coronary. This is a LAD with some coronary artery calcification as well as some aortic calcification, and this is an echocardiogram here with some subclinical heart failure, maybe some biatrial enlargement, diastolic dysfunction, those types of things, maybe elevated BNP. So when you start to develop subclinical cardiovascular disease, you're now in that stage 3, you're on that spectrum that I showed earlier of being in a higher risk group. And then stage 4 CKM is like the patient that I presented, someone who has a clinical event and is really in that highest risk group that really needs the most aggressive care. And these are patients who've had coronary heart disease, heart failure, atrial fibrillation, stroke, and peripheral arterial disease. And they're also divided in stage 4 based on the presence of kidney disease or not. So there's it's a little bit more holistic look at the interplay between the cardiovascular system, the renal and kidney system, and metabolic. So in cardiology, we usually just see the tip of the iceberg, patients who are coming to us who have established cardiovascular disease. But the patients who are at risk for cardiovascular disease is a much, much larger group. It's estimated that 1 in 3 US adults has CKM. And so while we only see the group who has often cardiovascular disease, there is a much larger group of patients who have type 2 diabetes and who are very, close to being stage 3 or 4 CKM. And this is all really driven by overweight and obesity, which has been the elephant in the room and something that I think a lot of us have not addressed. I'll be honest, I was approached for being part of an obesity clinical trial about 4 or 5 years ago. And I said, I'm not an obesity doctor. Here's the name of our weight management doc. And now that it was about a GLP-1. And now that we have GLP-1s and they're approved, I realize I am an obesity doc, and we all are. And if you start paying attention to the BMI of the patients that you're seeing on a daily basis, it's almost the exception rather than the rule that the patient has a normal BMI. It's occasionally the really old, frail woman with atrial fibrillation who has a normal BMI. Otherwise, most of our patients, they're seeing us because really what's driving a lot of their cardio-kidney-metabolic dysfunction is the excess adipose tissue. So the number one thing that we want to try to do at all stages of CKM is to continue to reinforce lifestyle modification. So 4 health behaviors that I tell the patients that they are responsible for, that includes quitting tobacco and vaping, getting healthy amount of sleep. This was recently added to the last iteration, recommended 7 to 9 hours sleep a night, eating a heart-healthy diet. The new hypertension guidelines are recommending less than 2,300 milligrams of salt for those who have hypertension, ideally less than 1,500. Making sure you're having 5 servings of fruits and vegetables a day. And we all know kind of the rest of the heart-healthy diet. Making sure we're staying active, 30 to 60 minutes of physical activity every day. And then the 4 health factors that we can help, and we say, know your numbers, right? We want patients to come in and see their doctor at some frequency so that they're getting screened for blood pressure, cholesterol, their weight, and glucose. And no matter what stage CKM you're in, our goal is to have all of these be optimized and normal. The second goal for all CKM patients would be to have the blood pressure under control. And for most of our CKM patients who are stage 2, 3, or 4, we want the blood pressure to go less than 130/80. The new hypertension guidelines were just released in August. They recommend using the new Prevent Risk Calculator for patients who have not yet had any established cardiovascular disease. And if the Prevent Risk Calculator is under 7.5%, then the recommendation is lifestyle therapy, as you can see here on the right, for 3 to 6 months, and then consider medication. However, if the Prevent Risk Calculator is over 7.5%, then we really want to start therapy right away. And we're going to go through the algorithm. Also talk to them about low sodium diet and screening for secondary causes, optimizing medications, which I think of the ACD-MRA, ACE inhibitors or ARBs, calcium channel blockers, thiazide type diuretics, mineralocorticoid antagonists like spironolactone, and then it's now in the guidelines to consider renal denervation for resistant hypertension. This is the algorithm from the recent hypertension guidelines. Starts with does the patient have a blood pressure over 140/90? Our patient was a little bit under this, and so we would move down the algorithm. So then the question is, does the patient have existing cardiovascular disease? Of course, in our patient, that was yes. So we would want to initiate antihypertensive therapy at that visit, reducing the cardiovascular risk, get the blood pressure to goal less than 130/80. And then continuing down the algorithm, that's when you use that prevent risk score. And so earlier, more aggressive treatment is important, and home blood pressure monitoring also emphasized in the new hypertension guidelines. I just want to put up a reminder for any patient who has hypertension, which is about half of the US population. It's important that they have routine tests for looking for end stage effects of the long-standing high blood pressure. And this includes a CBC, basic metabolic panel, lipid panel, A1C, TSH, urinalysis, and urine albumin to creatinine ratio, also called a microalbumin, and an EKG. And I think the one that often is missed here is the urine albumin to creatinine ratio. It is something that typically, I think, has been done by primary care and has been a quality metric for diabetes, but it really should be done on any patient who you're seeing with hypertension if it has not been done in the last year. If you have a patient who has secondary hypertension or has resistant hypertension, not well controlled on 3 meds or poorly controlled on 4, we should be screening for some of these secondary causes. Really, pretty much everyone should be screened for primary aldosteronism with a renin and aldosterone. And then if no secondary causes are found, consideration of referral for renal denervation is now in the guidelines. Regarding other screening that we recommend per this new sort of holistic look at cardio-kidney-metabolic disease, screening for the health-related social needs, looking at food insecurity, financial strain, those types of things, which I think our systems health questionnaires have incorporated. I think we're asking the patients, but I don't feel like it gets integrated into our notes, and it's not presented to us all the time. Like PHQ-2 or PHQ-9 often alerts us to patients who have these needs. In our system, we have a website called Resourceful that we refer to our social workers and community health workers and connect patients who screen positive on our health-related social needs. But I think addressing food insecurities and things is critically important to helping address obesity and some of these CKM risk factors. For obesity, obviously, a lot of our patients get weighed at every clinic visit. We also do waist circumference. Our CA has, in her pocket a little, tape measure. We do waist circumference. It's required for our cardio-kidney-metabolic registry, but it is really important for helping monitor for benefit of GLP-1s and making, seeing improvements in people's abdominal obesity. For screening for the other metabolic syndrome components, those who have stage 0 CKM, it's recommended to screen every 3 to 5 years. So for a lot of people, you only theoretically have to go to the doctor every 5 years and get, these labs done. But if you have stage 1 CKM, if your BMI is over 25, you should be getting these labs, lipid panel, get your blood pressure checked, screen for, impaired fasting glucose, A1C, every 2 to 3 years. And then once you develop stage 2 CKM and have hypertension or diabetes, this should be done on an annual basis. We also should be screening regularly for liver disease. And I'll talk about the FIB-4 score in a minute, as well as for kidney disease. And that's where the urine albumin to creatinine ratio is very important. This needs to be done annually for patients with stage 2 CKM or higher. Also for those lower risk patients, stage 1 or 2 CKM, coronary artery calcium screening, which you guys are probably very familiar with, is reasonable for those in the intermediate risk group to guide intensification of therapies. There's also sort of some language in this advisory about heart failure screening with an echo and cardiac biomarkers such as BNP, but the timing and sort of who that should be done on is not well established. But obviously, SGLT2 inhibitors being indicated for patients who have elevated BNP and heart failure type symptoms, screening in high-risk patients may be beneficial. So the FIB-4 score is very simple. This is a screenshot from MD Calc. It is just 4 variables: age, AST, ALT, and platelets. It is not enough to just look at those values and only assess for liver fibrosis if they're abnormal. You would be surprised how many people have normal labs and have a high FIB-4 score. So a normal FIB-4 score would be less than 1.3 for a younger person. And for someone over 65, we use the cutoff of 2. And this is programmed in Epic. It took 24 hours for our system to turn this on. It blows into all my notes. And so it's something I don't even have to think about. And if the score is over 2 for someone over 65, we refer for a FibroScan, which is a liver ultrasound non-invasive test looking for liver fibrosis. And then we would refer to GI if they have evidence of fatty liver disease and fibrosis. And really the treatment is, again, GLP-1s and managing their CKM risk factors. For kidney disease, again, it's not enough to just look at their GFR or their creatinine. We really want to be screening for albuminuria, and that's with the urine albumin to creatinine ratio, microalbumin. Because if you can see here on the left are the GFR categories. Even if the GFR is over 60, here, if you have the presence of microalbumin, you would want to start treatment. Obviously, if they have proteinuria, you're going to want to refer to nephrology as well. But these are patients, a lot of these patients are in our clinics, and you wouldn't be able to tell based on their labs that they have kidney disease unless you're screening for this. So similar to the prevention guidelines, there are other risk-enhancing features of CKM that would sort of put someone at a higher risk for development of stage 3 or 4 CKM. These are things like chronic inflammatory conditions, patients who have psoriasis, rheumatoid arthritis, lupus, HIV, certain high-risk demographic groups, like South Asians, people who have a high burden of adverse social determinants of health, as I mentioned, patients with mental health disorders, depression, anxiety, and sleep disorders such as sleep apnea. And then there's the sex-specific risk enhancers. I'm sure you've heard from Dr. Saxena, history of premature menopause, adverse pregnancy outcomes like hypertensive disorders of pregnancy, preeclampsia, eclampsia, preterm birth, small for gestational age infant, polycystic ovarian syndrome, as well as erectile dysfunction. All are risk-enhancing features for cardio-kidney-metabolic syndrome. Going along with the inflammatory conditions, isolated high sensitivity CRP over 2 is also considered a risk-enhancing feature, and then a family history of kidney failure or diabetes would also put someone at a higher risk. So if you see someone who's overweight or obese, has any of these additional features, again, we want to be more aggressive about screening and managing those risk factors. If someone does have diabetes-related kidney disease, which is quite common, And a way, again, to screen for that is with a urine albumin creatinine. There are 4 pillars of management for reducing the cardiorenal risk in these high-risk patients. The first is one that we're very familiar with, been around a long time, is renin-angiotensin-aldosterone blockade with either ACE inhibitor or angiotensin receptor blocker. That is grade 1 recommendation. Anyone who has evidence of kidney disease really should be on even a low-dose ACE or ARB. In addition, consideration for SGLT2 inhibitors, such as empagliflozin or dapagliflozin, and the non-steroidal mineralocorticoid antagonists like finerenone, and then the GLP-1s. So just like we look at guideline-directed heart failure therapy with 4 pillars, we need to start thinking about diabetes-related kidney disease and the effects that that's going to have on the development of heart failure and cardiovascular disease, and making sure our patients are also on optimal guideline-directed therapy for their kidney disease. The next goal is to manage their lipids. And I think this is the one area that we probably are the most comfortable with. The acute coronary syndrome guidelines were released earlier this year, and probably you're familiar with the more aggressive LDL goal for anyone who has a history of ACS of less than 55, and adding a non-statin therapy for really anyone who's LDL at the time of event on a maximally tolerated statin is over 70, and to consider also adding non-statin lipid lowering agents for those whose LDL is below between 55 and 69. My approach on everyone is usually to start a high intensity statin or intensify if they're on simvastatin 40 that they've been on, for 20 years. And then I usually change to either atorvastatin 80 or rosuvastatin 20, add Zetia at the time of the hospitalization, and then earlier initiation of PCSK9 inhibitor I think is critical. And so either evolocumab or alirocumab or inclisiran if patient is wanting to not give themselves an injection. And why do we do this? Why do we want lower, more aggressive lipid lowering? These are, a scatter plot of the major lipid trials for both secondary prevention in blue and primary prevention in red. And as we can see, the event rates on the y-axis are significantly reduced with the more that we push the LDL lower. And we're, again, very familiar probably with the Fourier trial, just to show the reduction in events. In that study that was from 11.3% in the placebo arm down to 9.8%. And the way that they were able to achieve this reduction in events was really by reducing that LDL to about 30. So I often see my partners, when I get them on a PCSK9 inhibitor, backing off of their statin and their Zetia. And really you want to continue that aggressive triple therapy, and the benefit in these studies is with this very low LDL, maintaining it less than 55. And if anyone was at AHA, the Vesalius trial was just presented and had a similar significant LDL lowering, the median LDL. This is in high-risk patients. This is evolocumab for those middle 2 groups that I showed on the earlier slide. The median LDL was 45, and again, similar significant reduction in events. Rather than the placebo group having an event rate of 11%, we're seeing an event rate of 8%, still quite high for this group, but with a significant 25% relative risk reduction in the group that got the PCSK9 inhibitor. So at this point, we have obviously statin therapies, but we have a lot of non-statin therapies that have a lot of benefit, both on LDL, some benefit on Lp(a), benefit on apolipoprotein B reduction, and not as much, influence with these medications on high sensitivity CRP, but that is a whole emerging field that we're still learning about. Obviously, the most potent medications here are on the right that we use routinely, inclisiran and alirocumab and evolocumab, the monoclonal antibodies. And there's a number of different clinical trials evaluating some new oral PCSK9 inhibitors. Also, some of that data was presented at AHA. I'm not going to go into details, but just to say we have a lot of different non-statin therapies that can get us to goal. And I think at this day and age, it's not acceptable to leave patients with LDLs that aren't at goal. Outcome trials, again, are in process, but initial evidence suggests pretty significant reductions in LDL, and so we'll have to wait for those outcome trials like V1P, V2P, and the Azure trials in the next coming years. Again, high intensity statins are really our mainstay of treatment, but as we know, there's this not insignificant portion of patients who just either refuse to take them or cannot tolerate them. So again, my approach to lipid lowering in these CKM patients, something, to address sort of the HMG-CoAs reductase pathway, either the statins or bempedoic acid. Zetia is in the guidelines as second line cholesterol absorption inhibitor, and then inclisiran and the monoclonals. And then obviously there's a lot of other agents. We have a couple patients who have heterozygous familial hypercholesterolemia, who've had events that we have on ivanicumab or Evkeeza, which is an LDL independent pathway. In addition to targeting LDL, which I think is critically important, we also can't ignore lipoprotein little a. An LP little a should be checked once in everyone. It's very prevalent. About 20 to 30% of the population has it, most often in African Americans, followed by South Asians. It leads to a disproportionate burden of cardiovascular disease as well as aortic stenosis. There aren't as many Lp(a) particles in the blood as LDL, but they are much more proatherogenic and potent. And so when you look at all of the lipid studies that we have, and the more evidence that we have, there's all these new targets that we can address to manage the lipid dyslipidemia. So we have LDL receptor, PCSK9, ApoB, ANGPLT3, ApoC3, and Lp(a). And there's more and more targets and drugs that I'm not going to go through all of them, but just to say this is a really exciting field to be in that there's so many new targets, either injections or small molecules that are oral, that are in phase 2 and phase 3 clinical trials, targeting all of these different areas to help reduce cardiovascular risk. Some of the ApoC3 are more targeting triglycerides, obviously Lp(a). We're waiting on outcome trials for pelacarsen, olpasiran, et cetera. The other future therapy for lipids that I think is really exciting is the CRISPR technology. This was published a couple of years ago of a CRISPR-Cas9 mRNA, one-time injection in non-human primate with sustained Lp(a) lowering at 365 days with a 95% reduction in the Lp(a). And so the CRISPR-Cas9 technology has been, was also presented at AHA for ApoC3, and there's a lot of, obviously we need larger studies and longer term outcomes, but it's amazing to think that you can get a one-time IV therapy and then have basically potential cure of your cholesterol disorder. So I think the future of how we're going to look at lipid disorders will be, potentially at the newborn screen. You would get whole exome genome sequencing, and if you have monogenic mutations, you'll be getting targeted therapies. And then we'll be looking at polygenic risk scores in the second and third and fourth decade. We'll be looking at calculating those risk scores and tailoring therapy once patients, hopefully, if we've done a good job at preventing their CKM, otherwise, once they develop some of the CKM stage 1 and 2, being more aggressive about those risk factors and using these therapies in those selected patients. But there's definitely a push towards prevention and identifying those therapies earlier. Triglycerides, as I mentioned, there are some new therapies targeting ApoC3 that are approved for patients with very high triglycerides and pancreatitis, as well as icosapent ethyl or Vascepa, which I use once I get the LDL under control if the triglycerides are still over 150. After I've addressed the lipids, then we look at weight loss strategies and obesity. It's recommended that most of these patients have a 10 to 15% reduction who have CKM, and with behavioral changes, diet and exercise, that you're only going to get 5 to 10% lowering. We know, from bariatric surgery, that is obviously a more invasive approach, but you can get 10 to 30% weight loss. And so often we are still referring a lot of these patients to weight management, but increasingly the middle column is the anti-obesity medications, the single agents, the GLP-1s, the dual agents like tirzepatide, and there's now triple and quadruple agents that are in clinical trials. So the number of medications, both injection and oral for anti-obesity, are really expanding. And I think, again, becoming familiar with those like you are for what's coming down for lipids is really important for better managing our CKM patients. In terms of starting GLP-1 therapy, there's different titration based on if it is being prescribed for diabetes versus being prescribed for obesity with risk factors like sleep apnea or liver disease. So one reason we're screening for the FIB-4 score and getting the liver disease is for those patients who don't have diabetes. In order to get the GLP-1 covered, for example, for tirzepatide or Zepbound, if they have evidence of liver disease or sleep apnea, it's easier to get it covered. This is the titration, for example, for Wegovy, semaglutide, and then tirzepatide, Zepbound, every 4 weeks. And we educate our patients about the GI side effects. I usually start the first 3. I created a smart set in Epic, so it's easy to order the first 3 and then continue to up titrate. And really, we can get patients to their, significant weight loss often within 6 to 12 months. So we've talked a lot about the LDL biomarkers, triglycerides, Lp(a). There's also, it's important to check apolipoprotein B once you, again, have LDL at goal. There's some patients who have some discrepancies there, and you would want to be more aggressive in lowering the LDL if they have a high Lp(a), both Lp(a) and apolipoprotein B. The natriuretic peptides are also, important biomarkers for heart failure. That's why the new Prevent score has heart failure built in and has additional variables to be able to predict heart failure risk. And then obviously high sensitivity CRP is an emerging area with IL-6 inhibitors, sitagliptin and others, colchicine. I'm not going to go through the colchicine data right now, but just to say, checking for inflammation, I think, is important. How we manage it is still to be determined. So, talked about a lot of things, right? You only have, I don't know how long are your appointments?
30 minutes.
30 minutes. That's more than primary care has, right? So my dad here is a retired family physician. And how long were your appointments?
I had 30 to 60 at the start, but at the end of the point.
Yeah. So in 15 or 20 minutes, it's very hard for primary care to address all these issues. I think in cardiology, we have the luxury of time. We do have more time with patients. We don't have as much access, but we can at least get a plan going for all of these things. So you really want to look more holistically. We're part of the Cardio-Metabolic Center Alliance, which is a more collaborative approach to treating all of these conditions in a holistic, team-based, comprehensive care model. We partner with our endocrine and diabetes specialists, nephrology, GI. We're physically just a team of literally 3 people, a nurse navigator and 2 docs, and then a nurse practitioner who sees some of the follow-ups. And what has been shown with this holistic manner and I'll go through sort of the scorecard we have for each patient, is within 6 months, we can get almost everybody to goal. It does not take much, and we can send them back to their primary within a year, but really it's early upfront and a holistic approach to addressing all of the things I just went through. So in our registry for the cardiometabolic clinic, we can get the LDL to goal. These are based on patients' baseline when they come into the program. And this is at about a dozen centers. This is sort of the prelim data from a couple years ago. But we can get their LDL to goal, get their intensify lipid lowering therapy, get their weight down, get their A1C down. We can usually lower their total daily insulin dose, often with the use of the GLP-1s and SGLT2 inhibitors. And we get them on guideline-directed therapy, which we know has not been done sort of in the usual way that care is currently being delivered, because everyone sort of thinks it's someone else's job to start the GLP-1 or to intensify the lipid therapy or to address their obesity. And so when you have it in a cardiometabolic clinic where all of those things need to be addressed at that initial visit, with a plan for follow-up to continue the education, we can double the use, of guideline-directed therapy for cardiovascular disease and diabetes or kidney disease. This is our scorecard for our patients. They're different. These are different guidelines than what you would use for your health system. We want everyone's A1C to be under 7. We want the LDL either below 70 or 55, depending on what their prior history is. Blood pressure should be less than 130 over 80. Everyone should have an NT-proBNP for screening for heart failure and Lp(a). Everyone needs a urine albumin to creatinine ratio and assessment of the GFR. We calculate the FIB-4 score on an annual basis. We do waist circumference and BMI, as well as assess for the need for specific therapies for targeting these cardiovascular risks. So weight management, it's largely GLP-1 therapy. I will say we focus mostly on diabetes, and so it's a lot easier to get the GLP-1s covered for diabetes than it is for weight management or obesity without diabetes. For glycemic management, again, the GLP-1s and SGLT2 inhibitors are really the mainstay therapy, and we really try to get people on dual therapy. Blood pressure, it's ACE inhibitors or ARBs, like you talked about, calcium channel blockers, thiazide type diuretics. Often, I switch people's from, hydrochlorothiazide to chlorthalidone. If we get someone on ACE or ARB that has maybe not been as effective, a lot of the nephrologists prefer irbesartan. So I've been switching people to 150 and then 300 milligrams of irbesartan. It seems to have potentially a little bit better benefit over over losartan. The spironolactone is the fourth agent that we're often adding when we see resistant hypertension patients. Again, lipid management we went through, and then for those who are having either heart disease, heart failure, kidney disease, these are the guideline therapies. And again, across the board, you can see here SGLT2 inhibitors and GLP-1s. And so we no longer can think about these diseases in silos because the benefits of these medications are really across the CKM spectrum, which is why we really need to think more holistically about how you're seeing these patients. And it's hard to unsee them once you've started taking this approach. You can no longer just see an AFib patient and talk to them about ablation without also addressing the obesity, the sleep apnea. There was a study, a Transform AF study, I think presented earlier this year on GLP-1 therapy preventing recurrent AFib episodes after ablation. Metformin in non-diabetics also has been shown, I think it was presented at AHA, to reduce recurrence of AFib in obese patients without a significant reduction in weight. So some of these medications are for AFib, are for targeting heart failure, and are really important for treating our cardiovascular conditions. The Cardio-Kidney-Metabolic initiative was launched by the American Heart Association last year. They actually just acquired all of our centers, all the cardiometabolic centers. So we're now part of the AHA. And within 4 years, they're hoping to have 150 certified centers and reach over 265,000 patients. There's going to be a registry. There's a lot of education and training recognition program. And like I said, there will be guidelines coming out. So if you have people who are interested in starting a cardiometabolic program, it doesn't take a lot. I mean, it just takes a core group of people who are really dedicated and can do a lot to improve the health of the patients in your clinic. So sort of in summary, this is the patient I presented at the beginning, stage 4 CKM, no longer a STEMI patient, right? A stage 4 CKM, high risk, had a stent to the RCA, has diabetes, high cholesterol, history of tobacco. This is what I would do for her. So I would check a high sensitivity CRP, potentially consider colchicine. If it is elevated, keep her on her DAPT, aspirin lifelong, keep her, probably consider beta blocker. I don't know why she wasn't on it unless she had bradycardia. For hypertension, I would get her to goal. I would probably start an ACE inhibitor or ARB. For her diabetes, I would repeat her A1C, comprehensive metabolic panel, CBC, and microalbumin if they hadn't, well, they were done in the hospital. So I'd probably repeat them in 3 months to see how she's doing. Calculate that you need the liver function test and the platelets from the CBC and the CMP to calculate your FIB-4 score. So that's why you want more than a basic metabolic panel. And then starting SGLT2 or GLP-1, and then stopping the glipizide, that's what's going to cause your hypoglycemia, and then getting her on an angiotensin receptor blocker and considering finerenone in addition to your ACE inhibitor and SGLT2 inhibitor if she has microalbumin. For the cholesterol, we're going to repeat a fasting lipid panel. I usually check a lipoprotein little a once and an ApoB once I get the LDL to goal. The LDL goal for her, given her ACS, would be less than 55. You could even argue lower than that with her diabetes. This is usually going to take a statin, Zetia, and a PCSK9 inhibitor. I would also consider icosapent ethyl for her triglycerides if they weren't at goal once we get her diabetes under control. And for the BMI, I usually tell them what their BMI is. Your BMI is 35. Normal is under 25, anything over 30 is obese. Have you heard of these new medications? And almost everyone these days has either had a friend or a family member who is on them. They, are sometimes embarrassed to bring them up, but once you bring them up, they are interested in undergoing some intervention to help lose weight. I usually will still refer them to the dietitian this patient, should be going to cardiac rehab. They can see the dietitian there. We can work on exercise, but really if they can't achieve the 10% weight loss that they need, I think additional GLP-1, especially with this person's history of diabetes, is imperative, and starting sooner rather than later is important. I always talk about smoking. We have about 30% prevalence of smoking in the iron range clinics. It's very, very high. It leads to a lot of cardiovascular disease. And so we talk about it a lot, and because that's really their number one, modifiable risk factor. So the patients that we're asking our cardiologists and our primary care to refer to us are, anyone who's high risk for CKM, any of the stage, 2 and higher patients. Stage 3 are the subclinical, people with abnormal coronary artery calcium scores. And then the stage 4 are a lot of those patients that are being seen by the cardiologist, but they're not being properly managed in this holistic approach. So those patients who you have with diabetes, who have established disease, or who have very severe lipid disorders, who are not on optimal therapy, I think are good patients that this sort of cardiometabolic clinic can really approach. And it's some little different model than just a pure prevention clinic. So in summary, everyone should aim to be CKM stage 0 and to maintain stage 0 for life. And if you end up finding yourself in stage 1 or 2 CKM, you should do everything that you can to focus on life's essential 8 to really get back down that spectrum so that you have a normal BMI and a normal blood pressure, normal cholesterol, normal A1C. But if you are in that middle, stage 2 or 3, we really need to be doing a better job screening for the kidney complications, the liver complications, sleep apnea, and using these guideline-directed therapies, not in silos, like you need to go see diabetes to get that medication, or you need to see weight management, but really as cardiologists, we are obesity doctors, we are lipid doctors, we're diabetes doctors, we're everything. Most of our patients are stage 4 CKM and really need us to at least start to, sound the alarm that this patient is at very high risk for having subsequent events. And if you don't feel comfortable prescribing these medications, find someone in your group who is, or educate yourself. They're not actually that hard once you've done it, let's say 3 or 4 times. So with that, thank you for your time. Happy to answer any questions.
Yeah. So I'm going to ask you about BNP. When you think about LDL, nothing is a risk factor. If you have it, we treat it. And if you have a clinical event, it's part of guideline-directed medical therapy. I'm a little surprised that when it comes to pro-BNP, we perhaps identify it as a risk factor. If you have it, we don't do anything specific for it. If you have a clinical event like heart failure, then suddenly it becomes part of guideline-directed medical therapy. Why isn't it a bigger deal? And why don't we go after it earlier as a marker for a high-risk condition?
Yeah, so the question is regarding BNP as a marker and how we sometimes check it, sometimes elevate it, but we don't really start addressing it unless someone's had an event, right? And then we really are trying to do everything we can to treat that stage 4 CKM, the patient who has heart failure, when really, and that's where I think that subclinical disease stage 3 screening with echoes and biomarkers, I think is going to be. I'm not on the CKM guidelines, but my understanding is that we're trying to better define when we should be using that information, and then the treatment often is with SGLT2 inhibitors early. And I think right now screening for kidney disease is a good way to look for that, the microalbumin, because that would be an indication, and a lot of these patients end up having that indication. And so even though they haven't necessarily had a hospitalization for heart failure, having multiple elevated BNPs, diastolic dysfunction potentially on an echo, even without a lot of clinical symptoms, I think would potentially warrant earlier consideration of SGLT2 inhibitor personally. Yeah.
Thanks, Kim. Appreciate the talk. Just that STEMI patient alone, there's so much to cover in that initial appointment, as you illustrated. And one thing I always appreciate, especially in guidelines that often gets overlooked, is those 4 behavioral aspects that people can do to exercise, nutrition, sleep, and smoking cessation. Obviously, there's no way we have time to cover those time-intensive topics in our 30 minutes. You touched on it briefly, but wondering if you could expand on any other offerings that you give to patients from a resources standpoint. That is just so crucial, but we just don't have time, and it often gets overlooked.
I think it's an important aspect. I try to bring it up with everyone, and I blame the AHA. So the AHA says you need to get 30 to 60 minutes physical activity. What's the most active thing you've done in the last week? You know, and like for, you know, a lot of people have just been shoveling, you know, how did that go? Right. And, you know, if it didn't go so well, you know, you probably, you know, everyone probably needs more exercise. I mean, you know, we have busy jobs. We do a lot of sitting, right? You know, sitting is the new risk factor, right? We all sit at computers most of the day. So I tell them the AHA says this, and it's walking. You know, it used to be 10,000 steps. They found that 8,000 was the same as 10,000 in terms of cardiovascular benefit. So a lot of people have these smartwatches and things that track their steps. You know, sometimes I'll have them pull it up. It doesn't take very long to say, how many steps did you get yesterday? And it's like 2,300. You're like, that's not enough, right? And so just I think making people more aware about the need for exercise. The salt is a huge one. I mean, I think most people have no idea how much sodium and salt they're taking in. I tell them just to not change anything, but just start tracking what you're eating. We have a dietitian, you know, with cardiac rehab, so those patients get the education. Otherwise, I refer to either the diabetic educators for people with diabetes, or to weight management program. I would love to have a dietitian in our clinic physically, but we don't have resources for that. Smoking obviously also doesn't take a lot of time. You can usually smell it when you walk in the room. And so you just say how many cigarettes you're smoking a day, and then, you know, how long have you quit for in the past? Are you thinking about cutting back or quitting? Have you picked a quit date? You know, what have you done in the past? Do you want any resources? And almost everybody wants to quit. I mean, I have very few people who are like adamant that they're never going to quit. And you can usually make some progress. And I think addressing those lifestyle behaviors, sleep, I ask more about. Snoring and refer for sleep study if abnormal, but it doesn't actually, maybe takes 2 minutes of your 30 minutes, and you can really get through those lifestyle recommendations on everybody. I don't know how effective I am, but at least it's in my DAX notes now, and so then they can read it later.
How frequent do you see this patient, and do you recommend ambulatory monitoring of like blood pressure, glucose, the fitness test that you mentioned? And then also recently, the American College of Sports Medicine announced that CMS, it has approved payment for physical activity assessment. Like I think $20 per hour for 15 minutes. I assume it's going to be for a clinical exercise physiologist. So have you thought of incorporating a clinical exercise physiologist in your team?
I mean, I wasn't aware of that. I think that is, you know, great. We have a phase 3, you know, there's a typical phase 2 clinical cardiac rehab after people have heart surgery or events. And we have a self-pay phase 3, and we have cardiac rehab at all of our outreach centers. And so we have majority probably of our cardiac rehab patients are just using it like a gym. You know, they like coming in and they're, you know, they pay, it's like $5. It's very inexpensive for them to use to continue in the program. So I think having something like that, they're not supervised with the tele like the phase 2 patients are, but obviously having access to a indoor place in Minnesota, northern Minnesota, that you can exercise in the winter is really important. I have some patients in Hayward that just do laps around the Walmart. It's the largest indoor track in that area. And they literally they have like a walking group, and they walk around Walmart. So I mean, I do think whatever we can do to help improve access to exercise tools for patients. I know there's been talk about the silver sneakers getting dropped from certain Blue Cross or other programs. You know, that's going to obviously affect those healthier, older adults. And I think there's going to be a lot of changes in the new year, but really we all as a society need to do more to kind of keep people in the stage 0 CKM. And we have just a huge and growing problem with, you know, obesity, but exercise is really, and incorporating walking into your daily. We walked a long way from the parking garage to get over here. You know, it's actually, you know, beneficial. I tell people park far away and just include more walking. But a lot of people work from home these days and don't even get, you know, hardly 3,000 steps in, you know, going to the bathroom and kitchen a couple times, you know.
I think the difficulty has always been for physicians. Difficulty for physicians is getting people to change their lifestyle, which is most of what this is. And I was in family practice for 40 years, and you saw the patient in their 20s and 30s, BMI of 30-ish, and watch them over the years go to 35 to 40, see them eventually get diabetes, high blood pressure, high cholesterol. And I used to try to tell them, I can either you can either try to lose weight, or eventually I can prescribe 2 or 3 medicines for your blood pressure, 2 or 3 medicines for your cholesterol, and 2 or 3 medicines for your diabetes. I think if you can try to frame it that way, I think we need to put much more attention on obesity. I think, unfortunately, I think it's largely genetic. I think, I wish there would have been GLP-1 drugs available when I was in practice. I don't know, I know why the insurance companies, they don't want to cover it because there's such a epidemic in this country that the cost to give everybody the cost doesn't have to be that much, but that's a different story, right? So,
Yeah.
I think there's more needs to be made on trying to treat that obesity.
Thank you. I agree.
Well, my takeaway is it's a lot easier to treat a heart attack than to prevent one. My, compliment to you for both of you. It is a really difficult task, but what do you do for your patients who primarily have an elevated lipoprotein lowering? And just because you're recommending screening and now we're gonna find it, so, and as you said, we don't currently have the greatest, or your comment.
Yeah, I actually just gave a talk at the Midwest Cardiovascular Forum about LP(a) being the silent assassin, and it was you're right. We don't currently have any approved therapies. We have a number of therapies in clinical trials that are targeting the kringles and the ApoA molecule, and seem to be effective at lowering LP(a). Whether that's going to translate to reduction in events is what we're waiting for. So right now we do have, I would argue, some therapies. The PCSK9 inhibitors, as I showed, do have some benefit, more benefit in people whose LP(a) is higher. So I do try to, if I can, I mean, I still will put them on a statin first, but as many of you probably know, statins actually potentially increase LP(a), so I don't ever recheck it because they don't want to know that it went up. But I still think getting their LDL lower is my first priority, but then I have a very low threshold. If their LDL goal is 70 and they're 72, I will add a PCSK9 inhibitor if they have LP(a) of 250, or I have 2 patients who have greater than the upper limit of normal 720 LP(a). And so very low threshold right now to get people on PCSK9 because it has some benefit. I mean, there's some other agents, potentially in the past, like niacin and estrogen and other things potentially had some impact on LP(a), but we still need the outcome trials, so it'll be a few years.
Katie, fantastic talk. I must say, I've never ordered a urinalysis looking for the albumin creatinine. Should we be doing that on everyone? And like Scott's point, can you remind me what we're going to do with that info?
Yes. So I would say, for diabetes, it's been at least at Essentia in the quality metrics for primary care to be assessing for microalbumin. But if patients are getting their primary care either not regularly or at other systems, it's often something that I think is often overlooked. And so I just look back, just like LP(a), I type it in the search bar at the top, lipoprotein, see if they've had any lipoprotein(a) ever in the past. And if they have, I don't need to recheck it. For microalbumin, if again, I just type in microalbumin because that's the name of our test. And if it's been done in the last year, great. Most of the time it's either never been done or it's been done 5 years ago and hasn't been reassessed. So I think the frequency that you need to do it depends on which stage CKM they are. Really, probably for screening for kidney disease, almost should be on an annual basis for those stage 2 CKM, which is almost all of our patients. Hypertension, diabetes, high cholesterol, and what you would do with it is really SGLT2 inhibitors, and if they have diabetes with the kidney disease, ACE inhibitors, ARBs. So we're not necessarily just using the ACE and ARBs for blood pressure anymore, right? Just like we use them for heart failure, we would be using them for kidney protection in addition to the SGLT2 inhibitors. And then consideration of finerenone. I've not prescribed a lot of finerenone. There's been some cost issues, but that is something that I think we also will need to be more familiar with and comfortable with in the future. So that would be what you would want to do. I know we're at time, so I'll let you guys get to your clinics. Thank you very much. I'm happy to answer any questions after.